Thank you very much. This is a topic which I think is of tremendous public health importance. The marijuana is something that comes up in the news almost on a daily basis. And it's been quite intriguing to see over the last 10 years how the sort of discussions around marijuana have shifted. And we now have this term medical marijuana, which has really emerged into our language in the last 10 years. And gives rise to a lot of discussion. It certainly gives rise to a lot of controversy, a lot of policy development. But intriguingly, there's been an incredible amount of science that's gone on to understand just what cannabis is and how it works in our bodies. And trying to take a topic like marijuana, which has really been traditionally studied as a drug of abuse, and to try to find ways in which it could be harnessed and to have some therapeutic use, some way in which it could be used to improve health and to reduce pain in particular, is really quite a challenge. And as a researcher and somebody who was brave or stupid enough to try and take this on 10 years ago, it's a real pleasure to actually be able to present some results and to present some of the findings that we and others have been discovering in this area in the last 10 years. So without further ado, let me jump right in, and I'd like to begin by reminding you that pain as a syndrome, pain as a disease, and I'm sure you've heard this said in the last few weeks, we now think of chronic pain really as something rather like high blood pressure or diabetes as a chronic disease. People who live with chronic pain have to deal with it on a daily basis. It affects many aspects of their lives. And the idea of chronic pain as a syndrome that we have to manage, it really impacts us when we start talking about pharmacology. And when we start using medications to treat pain, we realize that we have some really good painkillers that are good at treating acute pain. So on the left-hand side, yes, on your left, the acute pain syndromes, when you injure yourself acutely and you're seen at the emergency room or you take an Advil for your headache, I mean, we know that we've got pretty good analgesic medications for treating acute pain. What happens is that pain persists for days, weeks, months, and the pain continues. We now know, as I'm sure you've heard, that there are changes in the nervous system, changes in the brain, changes in the spinal cord, which make that pain much harder to treat with medications. So we have very few effective medications in treating chronic pain. And as a physician who works in a pain clinic at the Montreal General, our clinic is filled with patients who have had pain for years, have really had very little success in managing it, and we have to embark on a very multidisciplinary approach using physical therapy, psychotherapy, and pharmacotherapy to try and get that pain under control. We don't talk about pain cure, we talk about pain management. We try to help patients cope with their pain, manage it, understand it, and try and find ways that they can live with their pain more effectively than they are. Today's talk is really going to focus on pharmacology. We're talking about medications, but I want to state right at the outset that it really isn't the only way that we have to manage pain. We'll be focusing a little bit on that, but when we see patients in a chronic pain management unit, we are really talking about using many different ways to manage pain, and this is really going to narrow down on some of them. And as this slide shows you, the drug efficacy that we have for the drugs that we try to use to treat chronic pain are really limited by side effects, by poor efficacy. Some work for some patients, but we're struggling with many patients. And this is where my story around the medical uses of marijuana began, because I started to see patients coming in who had really tried and failed most of the conventional therapies that were out there, but who reported these phenomenal responses when they smoked a little bit of marijuana. And one patient said this to me one day in the clinic, and I went back to my computer and I opened up the PubMed and I did a search for marijuana and pain, and I was astonished to find the science that had been going on in laboratories around the whole cannabis system. And that's what I'll be focusing a little bit on today. But I realized that there were very few people who were actually trying to take that knowledge from the science, from the basic science, and put it into clinical practice, and to take that story that the patients were telling me and actually try to put that and harness that information and put it into clinical practice. So really that's where the story began. It was a lack of good treatments for chronic pain, and maybe there was something in marijuana that could help to tackle that. So just to remind you, and I apologize if you've kind of gone through this in the last few sessions, but just to remind you that when we talk about a pain pathway, we tend to think about typically a pain injury, which would have, for this poor man has cut his wrist, and he has a pain message which travels up this nerve to the spinal cord. The message is then taken up into the brain, and it's somewhere in the brain that he perceives the feeling of pain. And that's a good, useful pathway that we need. It tells us to move the hand away from the toaster oven or to run away from the injury. And this is a normal pathway. We all know what it is, and everybody's experienced what pain is. If we dive a little bit deeper into the spinal cord, it's important to recognize that these nerves connect with one another at synapses right in the spinal cord. And if I can get this little mouse to work, right around there, the nerve coming in from the periphery, from the arm, synapses with another nerve, and that second nerve takes the message up to the brain. And you've probably also heard that in parallel with this ascending system, there's a descending pain pathway which comes down from the brain and actually modulates some of those signals of the pain coming in from the periphery. So in here, there's a very, very intriguing gate mechanism. And Ron Melzack from McGill years ago was the first with Pat Wall from London to really explore this idea that there was a way that we could gate pain in the spinal cord. And this is where some of our story will take place. If we actually look at that synapse, if we look at where the two nerves come together, and they have to part. This is where we get into the chemistry, and Dr. Schwartz will be pleased to know that we're now into the pure chemistry of pain. But this is where the electrical signals, which are passing from one nerve, have to be converted into a chemical messenger, which travels across the synapse, across this gap, and then binds to a special receptor on the second nerve, the postsynaptic membrane. And if that message if that chemical bonds with enough power and with enough number, it's enough to trigger that second nerve to stimulate an impulse, and the message continues up the pathway. So this is a very important sort of crossing point for these nerve signals to take place. Many of our medications that we use to treat pain are acting right at this synaptic point. This is where the drugs go to block or affect the transmission of pain through these pathways. And when someone's had pain for a long time, those pain messages have been bombarding this second nerve for months or years. It changes the morphology of that membrane, and it can change the whole receptor profile. So a chronic pain really is a very different beast than an acute injury. So we have an ascending system, which is the pain traveling up to your brain, so you feel the ouch. You have a descending system, which modulates that. And again, perhaps Mick Sullivan mentioned this in his session, but this descending system is something that we can actually use, and we do use, when we need to somehow get away from the pain. An athlete who injures himself in the course of an event will continue to function at some level because they can suppress the pain and continue to finish the game or finish the event. They can suppress that pain signal. They're doing that by very powerful psychological techniques. We can harness that system as well using pharmacology. And this slide will show you how the different pain drugs that we use affect these pathways at different levels. So drugs that affect the ascending system, the messages going in, include Tylenol, acetaminophen. This is, we don't really know exactly how Tylenol works yet. I can go into a little more detail if you're interested. There's actually a cannabinoid twist to it. Acetaminophen, anti-inflammatories, block the inflammation at the site of the pain and therefore reducing the amount of pain signaling going up. Anticonvulsant medications. We're beginning to recognize how some of the drugs that we use to treat epilepsy also have a very powerful role in treating pain because they can suppress the transmission of pain. Opioids, of course, morphine and the morphine classes of drugs are also very powerful at suppressing pain signals coming into the brain. Local anesthetics, of course, anyone who's had a dental procedure and had a local anesthetic put around a nerve, it stops the nerve from sending pain pathways so the dentist can go to work. We also have drugs that can work on the descending pathway. And these are really intriguing because they tend to be different classes of medications than you might think as being effective for pain. Antidepressants, tricyclic antidepressants, amitriptyline, Elavil, these are very, very intriguing, very old compounds, but which work on the descending system to enhance our ability to suppress pain from the top down. the serotonin and norepinephrine reuptake inhibitors, also antidepressants, drugs like Effexor, Cymbalta, duloxetine. These are chemicals which enhance our body's own ability to suppress pain by blocking the reuptake of important messengers, which, when we leave them in the synaptic cleft, can help to suppress those pain signals. The big challenge, one of the big challenges in pain management, is explaining to a chronic pain patient that you're prescribing an antidepressant not because they're depressed, but because they're actually quite good at suppressing pain. And these drugs are actually approved and prescribed as analgesic medications. But of course, they're still described in the pharmacy as antidepressants. So we often get phone calls saying, you know, prescribing an antidepressant, I'm not depressed, I have pain. Anticonvulsants also work at this descending level, as do the opioids. But here's where we get into the marijuana story, cannabinoids. So we're now beginning to recognize that the drugs derived from marijuana, or cannabinoids, also play a potentially very important role in modulating this descending pathway, and that's where we're going to spend the rest of the session. So there's the plant itself, a gratuitous picture of marijuana. Marijuana, cannabis, pot, weed, grass, green, skunk, it's all the same thing. They're just street slang for the plant, Cannabis sativa, the Latin name for the cannabis genome, for the cannabis species. And it's an intriguing plant because it's been around human history for thousands of years. It's been cultivated for two main reasons. One as a drug, and the other as a plant for fiber and seed and oil, and for a long time, cannabis and hemp, which is the cannabis, fiber type cannabis, has been a friend to mankind for a long, long time. But they're both essentially the same genetics. They've just been bred by humans to do two very different things. They both actually look very similar. They smell very similar. And if you look closely at a flowering plant, so this is cannabis when it's in full flower. The leaf, the classic five-fingered leaf that everybody recognizes as the great icon of marijuana, is actually not that interesting. Where we're interested are the flowers of the plant. So when the unfertilized female plant expresses its flowers and starts to really bloom, it expresses on the surface of its pistils these tiny little trichomes. They're tiny glandular structures that the plant expresses all over the flower. And these are where the cannabinoids are found. Cannabinoids are chemicals which are unique to the cannabis plant. You don't find them in any other plant or animal material. They're synthesized by the plant. No one's quite sure why it makes THC. We think it may be because it protects it from the sunlight. It's also been very successful at enabling cannabis to continue to be propagated as people grow it in order to express this same cannabinoids. But suffice to say, these trichomes contain very, very high quantities of these cannabinoids. The most important one of which is this little baby here, THC, tetrahydrocannabinol, delta-9 tetrahydrocannabinol, which is the primary psychoactive ingredient in the cannabis plant. Cannabis in hemp form expresses very high amounts of another cannabinoid, but you can see the similarities in their chemical structure. But there's been some modification by the enzyme that manufactures these in the plant. And this cannabidiol, CBD, is not a psychoactive compound. If you smoke it, probably just gives you a headache. But it's actually been shown now to have some very important therapeutic properties by itself. So when we talk about cannabinoids in medicine, we're not just talking about THC. We're talking about these two compounds, but also a whole family of others which are related to these. They're isomers. There are various different changes in the structure of the little side chain that goes off to the side. But these cannabinoid compounds all are thought to have various different effects, both in anti-inflammatory effects. Some of them have antibacterial effects. They have anxiolytic effects. They have pain-relieving effects. So we're really at the cusp of learning what these compounds can do. And as we go further through the talk, I'll start to explain to you how some of these compounds are being put into clinical trials and being explored as potential medications. But turn the clock back a little bit, and perhaps to put some of this cannabinoid story into perspective, I'd like to just show you, and I think probably Dr. Joe went through some of this at the very beginning, but you know, the history of opioids as a medicine began in very much a similar way. We knew about morphine, or we knew about the opium poppy, we have known about it for thousands of years. But it wasn't until relatively recently that morphine, so in 1804, so a couple of hundred years ago, morphine was extracted from poppy and was purified and synthesized as an analgesic in Germany in the early 1800s. Then analogs. So diacetylmorphine, codeine, hydromorphone, oxycodone, which is the active ingredient in OxyContin, Demerol, oxymorphone. These are all just various different variations on the morphine molecule. Were all synthesized in the 1900s. And it wasn't until the 1970s when we actually began to recognize where it was these drugs were working. So they were great analgesics, and we knew that, but we didn't know where they were working. So in the 1970s, there was a discovery of specific receptors for the opioid compounds. Okay, mu-opioid receptors, delta, there's a family of different receptors which are the targets of the opioids. And at the same time, of course, when you have a receptor in your body, there's typically some reason why you have it. And it became clear that we have our own opioid-like compounds, the endorphins. And I think most people know now that we have endorphins which give rise to some pain-relieving properties. And in fact, it's those endorphins which play a role in some of that feeling of analgesia that athletes get when they're recovering or when they're running and continuing to function. They activate their endogenous opioid system, and that has very good analgesic effects. Well, the cannabis story is very similar. We've known about cannabis as a potential medicine. There are very old herbals from the 12th century on where cannabis is described as having properties of treating spasticity and tetanus and for treating arthritis and joint pains, menstrual disorders. The history is full of these kinds of descriptions. So the story for cannabis is actually shifted over about 20 years. And it wasn't until 1964, so this is actually 100 years after morphine, but when an Israeli scientist, Raphael Mekulam, identified THC. He was the first to realize that this was the active ingredient. Up until then, nobody really knew what it was that was giving cannabis its activity. And then in 1988 and the early 1990s, we discovered the cannabinoid receptors, the specific receptors that we have on our nerve cells which are responsible for the effects that the drug has. And of course, with the discovery of the receptors, the next question was, what are they doing there? Is there an endogenous cannabinoid system that we have in our bodies? And sure enough, there are a family of kind of compounds which we make all the time, which are acting on these receptors. And I'll come back to this right at the end, but this is a very, very powerful, and this is perhaps where we start to get into the story of how has cannabis taught us about pain. It's actually through the discovery of this endogenous cannabinoid system that we're beginning to realize we may have an important new pain pathway that we can start to target. We all have cannabinoid receptors. We all have endogenous cannabinoids. They help us eat, hunger, sleep, pain management, motor control. A wide range of normal physiological processes are under the control of our endogenous cannabinoid system. And when that system goes awry, we may be one of the reasons why we get some of the kinds of pain syndromes that we see in the clinic. So it becomes a potential target. Where are we finding these cannabinoid receptors? Well, the CB1 receptor, there are two major ones that we know about. There's CB1 and CB2. CB1 is probably the most well-studied of these receptors. It's just like all the other neurotransmitter receptors that you saw in that synaptic membrane that couple with internal signaling compounds. It's a classic G-protein coupled neurotransmitter receptor. But it's the most highly expressed receptor we have in our brains. It's found almost throughout the entire brain, and especially in various areas where, if you think about the effect marijuana has, it sits very nicely where you would expect to find them. And this picture of a brain, very schematically, in green shows you where the dense receptors are located. So right in the middle of the brain, this beautiful structure, the amygdala, the hypothalamus, the caudate nucleus, these deep brain structures are filled with cannabinoid receptors. They're very rich, and these play a role in memory, movement, decision-making, movement, anxiety, fear, temperature, feeding regulation, so the normal desires to eat and drink, and other areas, reward and addiction. You may hear more about this next week with Dr. Schweinhardt. And dopamine, which is one of the big compounds that she studies, is tightly linked in with these pathways. So somewhere in there, the cannabinoid system is playing a role. The question is, what exactly can we do with this information? Just to sort of fill the gaps, the CB2 receptor, which is probably the least well-studied of these two, sits mostly on immune cells. So the cells that circulate, the the white cells of your blood that go around looking for pathogens and help to clean up the immune system, are known to express CB2. We don't really know yet what the receptor is doing there. It's intriguing to know that our brains also have these immune cells. They're called microglia or astrocytes. And our brains are actually packed with these little immune cells, and they help to control the function. And they're quite rich in CB2 receptors. So we think that there may be a central nervous system role for the CB2 receptor as well. But that's really just an emerging area of science. So what's happening to these receptors? Why do we have them? The discovery of the endogenous cannabinoid system really was quite a landmark in this whole process, because it was clear that unlike most neurotransmitters, which are proteins or large molecules that bind to these receptors, the endogenous cannabinoids were fats. They're lipid structures which are derived straight from the membrane lipids, the fats that make up every cell membrane of your body. That the body actually makes these endocannabinoids from the lipids that are in the cell membrane and releases them into the synapse, and where they can have their effect on the CB1 receptor. They're made from very common fats. This is the fatty chain here of an arachidonyl phosphatidylethanolaamide, which is a fatty acid, and omega-3s and omega-6s. This is actually an omega-6, because you count back from here, 1, 2, 3, 4, 5, 6. There's the double bond at the 6, so that's an omega-6 fatty acid. And our cell membranes are filled with these omega-3s and omega-6s, and this omega-6 fatty acid is broken down by an enzyme into anandamide, which is probably the grandfather of all the endocannabinoids that we have. Anandamide was named because ananda is a Sanskrit word meaning bliss. It was thought that this was the sort of endogenous compound that could give rise to this feeling of well-being. And then once the receptor and the endogenous ligands were identified in the early 1990s, the race was on. What do these do? What happens if you knock out the CB1 receptor? What happens if you block it? What happens if you put a chemical in that binds to the receptor? What happens if you block or change the anandamide synthesis, and so on? So really the hunt was on, and the science has exploded in understanding what this system is doing in the brain. So just to give you the kind of really Reader's Digest version as to what we think the CB1 receptor and the endogenous cannabinoid system is doing, I'll try and talk you through this. I showed you a nerve earlier which binds to a second neuron across the synaptic cleft. What we think happens is that when this nerve here, the first nerve, releases its neurotransmitter, and there are many different neurotransmitters that we use in different cells in our bodies, when this transmitter crosses the membrane and binds to its receptor, it activates the release of these endogenous cannabinoids. So the body quickly manufactures a little puff, if you excuse the phrase, of endogenous cannabinoids, which diffuses backwards across the cell membrane, across the synaptic cleft rather, and binds to the CB1 receptor, which is located here on the presynaptic neuron. If my little arrow will wake up, I will show you, maybe I have to stop wiggling it so much. The little green receptor on the presynaptic terminal there is where these cannabinoids act. And what happens when that endogenous cannabinoid binds to that receptor is it suppresses the release of the neurotransmitter in the first nerve. So it's a way that the nerve has of backwards diffusion of suppressing that nerve from firing again. And it's believed now, because this receptor is so widely expressed in the brain and in so many of these synaptic situations, we believe that this is one of, if not the most important method by which our nerves tell each other, I've got the message, thanks, you can shut up now, and stops from firing. So this normal system, and these endocannabinoids are released, they bind to the membrane, they're picked up and broken down, and then they finish their job and they disappear. So they're very short-acting, very locally acting compounds, which suppress that nerve from firing. So you imagine a situation where a nerve is firing abnormally rapidly, epilepsy, migraines, chronic pain situations. You've got a nerve that's persistently firing a pain message, and you deliver a drug which binds to the CB1 receptor and actually slows that nerve's firing down and suppresses it from releasing potentially therapeutic effects, right? You can suppress that nerve from firing abnormally. And we believe that when a patient takes a cannabinoid from outside, in the form of THC in marijuana or in the form of some of the medications that we now have that use this system, we think that this is probably the mechanism, that it suppresses that abnormally firing nerve and calms it down. This may play a role in spasticity. This may play a role in anxiety disorders. And so we think that this is a very important target for therapeutics. So how do we use this in clinical practice? Well, we actually have in Canada, and I think we're probably one of the only countries in the world that has a small list of cannabinoid compounds that we can prescribe in clinical practice. We have a number of them. The newest kid on the block is a spray that actually combines the two main cannabinoids, THC and CBD, which are extracted from plants. They're grown in a special facility under very tightly controlled conditions, extracted and put into a spray, and it delivers a single dose of 2.5 milligrams, essentially, of both of those two compounds. And this has been approved in Canada for treatment of people with multiple sclerosis who have either neuropathic pain caused by the nerve injury that the MS causes, spasticity in MS patients, and it's also recently been approved for patients with really refractory cancer pain. The other compounds have been around for a long time. And when I first came here and began looking at this, and I realized that patients were telling us that we were using marijuana, I started to look and see, well, was there a drug that could possibly bind to these? And these were on and had been on the formulary in Canada since the early 1980s. Nabilone, which is a synthetic, very THC-like compound, has been approved for the treatment of nausea and vomiting for chemotherapy patients for a long time. It got kind of overridden by newer developments in antiemetics, so newer compounds to treat nausea, which were better and newer, and so they kind of took off. And this drug kind of got forgotten about, but it's a very potent agonist at the CB1 receptor. It sits tightly on the receptor and binds to it very well. And dronabinol, which is pure THC, has also been available on the formulary in Canada for about 25 years now. And it's approved also as an antiemetic for nausea and vomiting with chemotherapy, but also as an appetite stimulant in patients who have HIV/AIDS wasting syndrome. So one of the big features of HIV/AIDS was a loss of weight and a loss of appetite. And lo and behold, we know cannabis causes an increase in appetite, the munchies. Lo and behold, this drug, when given to patients with HIV, was also able to stimulate their appetite. And there's been some recent work by Canadian researchers in cancer pain where it didn't so much treat the cancer and improve their appetite, but what it did for the patients who took THC in those studies, or this study, was that it made them enjoy the act of eating more. It made the food more palatable. There was something about the drug that made the food seem like it was more enjoyable, and that was one of the effects they had. So we're still exploring what these drugs can do. And of course, the fourth legal cannabis that we have in Canada is the herb, the raw herbal cannabis compound, which we have through a very formal regulatory process in Canada. I'll come back to that later on. But we have tools that we can use to harness this system. So forgive me for showing you some data, but you guys are going to be scientists now, so I might as well show you some science data and show you some graphs. These are data from, I've just taken a small number of studies to show you kind of how we do pain research, for one thing, but also to show you the kind of effects that these drugs have. And this is nabilone. This is a synthetic cannabinoid in fibromyalgia patients. This is a friend of mine who works out of Winnipeg and who showed that if you gave this drug to people with fibromyalgia and you measure their pain, you can see here on this axis down the side, this is actually the most powerful way we have of measuring pain. There's no equipment, there's no machine that we can use to measure anyone's pain. We simply ask you, on a scale of 0 to 10, how bad your pain is. 0 means no pain, 10 is the worst pain you've ever had in your life. Everybody can score their pain on that scale. It's quite effective. Doesn't mean that I can compare your pain to your pain, but it means that if your pain is 4 out of 10 today and 6 out of 10 tomorrow, I can measure and track that pain over time. And sure enough, when we average patients over time, these patients who had a certain level of pain at baseline were able to show that after 2 weeks, and this first bar here shows you the separation between the placebo, which is the black line, and the dotted line underneath, shows you that the amount of drop in pain was greater in the patients who got the nabilone compound, this cannabinoid, and over 4 weeks at the middle there, you can see the two bars separating out nicely. The first one dips down because there's a placebo effect. It's very powerful in pain. When you give a placebo to somebody suffering with chronic pain, you almost always see a pain response in some patients, and that pushes these curves down. But you got a much stronger effect when you gave them the nabilone. And then when the drug's taken away, the pain returns back up to baseline. one of the things that I discovered when I was talking to patients who were using cannabis in pain control was that they often said, you know, the pain, it does something for the pain, but some of the effects that it had that were most profound when I interviewed patients was that it helped them sleep. So we did a study where we took this old cannabinoid compound, nabilone, we gave it to fibromyalgia patients, but we asked them not to score their pain, but to look at their sleep quality. Just gave a very small dose at nighttime before bed, and we asked them to measure their insomnia severity. And this scale here is another score. It's essentially you ask a series of questions about sleep. And you score it, and anything really above 18 is severe insomnia. These patients are not sleeping well at all, and so when they come into the study at baseline, you can see the the insomnia severity score very high. When you give them we had a control drug, which is amitriptyline. It's a tricyclic antidepressant which causes drowsiness, and so we use it quite often as a sleep aid in chronic pain patients. You can see both nabilone and amitriptyline improve the sleep score, so a low insomnia severity score is a good thing. You want to have a lower score. Then we took the drugs away and the sleep scores got back up to being bad again. The insomnia severity scores went up. We then gave them the drugs again and the sleep scores went down, and we took the drugs away. And so you can see this suppression of the sleep insomnia with these two medications. And in fact, this was the first study which compared a new therapy, nabilone, with a very old drug, amitriptyline, and showed that the two of them were roughly equivalent in terms of improving sleep quality. So we were able to, and we actually use this drug quite often now in the clinic. This is the study that first got me into most of my mischief, which was the idea that we could smoke cannabis as a medicine. And this was really pushing the envelope. And when I was speaking to Dean Grant outside, I said, you know, there aren't many places in the world where you could approach a university and a university hospital and say, you know what, guys, I think we should study this and actually have people take you seriously. And it's amazing that in all the experiences I've had here at McGill and at the MUHC, I've never had a roadblock to doing this research. I've always found, as long as it was done carefully and scientifically and you had a really good team of people around you, we were always able to find ways to get around the various different roadblocks that were present in trying to do this research. To my knowledge, there have only been 4 trials that have ever been done looking at smoked cannabis as a medication or as a therapy for pain, and this is the most recent. This was published in the CMAJ a couple of years ago. And essentially what we found, in order to do this study, and I could probably do an entire session just on how the study was set up and what we had to do to get it done, we had to take patients who had failed everything else that we had ever thrown at them. So they were extremely refractory chronic pain patients. The pain was caused by nerve injury, either through some surgical procedure or a trauma to the nerve, and they had persistent nerve injury pain, which is very hard to treat. And we administered cannabis in very small doses using a little pipe device. And you have the study in your handouts, so you can read more detail as to how it was done. But the patients took a small pipe, which we had to get approved as a medical device. We administered small amounts of cannabis, a single inhalation, 3 times a day for a week. And they were rotated between 4 different strengths of cannabis. One was a placebo, the 0% THC, so it had no THC in it. Another one had a low dose, 2.5% THC, 6%, and 9.4%. And we found that the 9.4% THC reduced the pain significantly compared to the others. Now, it's not a big effect. It wasn't a profound analgesia. We didn't really expect it to be a profound analgesia. We weren't giving patients large doses. But remember, these were patients, nothing was working. So even a small effect in this kind of population was important. We also found that their sleep quality was improved. And there was some suggestion that their anxiety levels were also somewhat better. So the cannabinoids in this study were affecting pain, sleep, and mood. And I'll come back to that in a little bit. We also looked at the blood levels. So they were taking a very small amount, and we measured the levels of THC in the plasma. And you can see that with the different strengths, the levels of THC go up to about 40 to 50 nanograms per milliliter in the high dose group, and then there's a dose response effect. So as you get down to luckily in the placebo group, nobody had any THC in the blood. Otherwise, we would have really been wondering what they were doing outside the study. But they flat lines, no THC, and what's important to recognize here is that in recreational marijuana smokers, when somebody takes a hit of marijuana from a joint or a bong or however they do it out on the street, and they're probably doing it 10 yards away over there, their levels of plasma THC are going up to 100, 150 nanograms per ml. They're getting a much higher plasma level because they want to have a psychoactive euphoric effect. That's why they're doing it. These patients were using very small amounts, and we found that even these levels where they really didn't report feeling stoned or euphoric. We had 3 episodes in what were 1,000 dose intervals during the course of the study. Only 3 times did the patients report feeling any kind of euphoria, and they occurred on all the different strengths. So it wasn't a powerful euphoric effect. What they were feeling was some kind of change in their pain. And again, we think that probably they were just tickling those cannabinoid receptors enough to suppress those nerves from firing to give them some pain relief. Now, smoking cannabis is really people say, well, how can you give smoke cannabis as a medication? Smoking's bad, and I agree. What's really intriguing is to know that what's coming down the pipeline now is this idea that you can heat cannabis to the point where it gives off those cannabinoids. You take that flowering material, heat it up to about 180 degrees, which is way before it will burn. But what happens is those oily droplets vaporize. They come off in a cloud, and that cloud can be captured. This rather ominous-looking device here actually has a heating element in it and a fan which blows hot air through this little trap. And if you put cannabis into a little chamber here, ground cannabis in, and catch the vapor in this, it's basically an oven bag, it blows up like a balloon, and it contains a cloud of this cannabinoid vapor, and you inhale that. You get almost exactly, and these are the plasma levels of THC from this study, and you see here the levels are around 100 nanograms per ml. These are recreational users. This wasn't a clinical trial. But what it showed was you got very, very similar plasma levels when you inhaled these vapors compared to inhaling cannabis smoke. And they showed that the vapor was far, far less in terms of the polyaromatic hydrocarbons and the ammonia compounds and all the toxins that we see. When you burn the plant material, it's burning those cellulose fibers in the plant that really give rise to the nasty stuff. Just the cannabinoids themselves appeared to be quite high, but none of the, not none, but a much, much lower dose of the toxins, and none of the tars that you get associated with tobacco use. So the idea of this vaporization, and there are, believe me, companies working very hard at making this kind of device portable and accessible and having them approved. There's actually a vaporizer which is approved as a medical device in Canada for inhaling cannabinoids, which gives us a reasonable alternative to smoking as a way of inhaling cannabinoids. Now, a question I often get asked is, why not just take it as a cookie? Why not just eat it or take the tablets or the spray? Or isn't there? The reason for that is that you cannot get these kinds of plasma levels when you take a THC orally. Your body, it takes a long time to get into the stomach, and then it gets broken down, it gets absorbed and taken into the liver, and the liver plays with it and spits out a metabolite. That then eventually gets to the brain. So the whole process takes about an hour and a half, and it's been changed along the way. So the effects in the plasma levels that you get with an oral THC are around 5 to 10 nanograms per ml, long, low plateaus of THC. You don't get that rapid onset. And for somebody who has an acute spike of pain or an epileptic seizure or a spasticity or a neuropathic pain crisis, they want something which works quickly and which gets a very rapid. So this, you can see the figure here. This is peaking at 1.5 minutes. Okay, so that's a very, very rapid onset of high plasma levels. Of course, it drops off by an hour. It's pretty much cleared from the blood. It gets absorbed into the fatty tissues and into the brain. But you get a very, very rapid onset. And of course, the vaporizer does the same thing. So it's a way of getting a much more rapid onset of the effect. So how are we going to use this in clinical practice? We have some medications. We know herbal cannabis has these compounds in it, and we certainly hear from patients that this is something that they want access to. And in fact, the courts in Canada declared about 10 years ago that access to herbal cannabis was something that patients had a right to have. If they could establish that there was a medical need, that it was unconstitutional to keep the drug illegal for such patients. And that's given rise to an incredible explosion of interest in this area, not just in Canada, but worldwide. And you can see here, these are data from the Medical Marijuana Access Regulations, which is Health Canada's program that authorizes people to possess marijuana. And you can see the different levels here. So you can see the program starting in, this is when they started giving figures, September 2002. By around December 2008, early 2009, the numbers of patients who were authorized to possess cannabis for medical purposes starts to creep up around 3,000 to 4,000. And then in the last 2 years, we get this explosion in numbers. And we're now up to around 15,000 Canadians who are authorized to possess cannabis for medical purposes. And it's important to point that out. And I often hear this, and when I get interviewed by the media, they say, well, doctors don't want to prescribe marijuana and so on. Doctors cannot prescribe marijuana. Doctors can authorize a patient to possess cannabis. And the reason that there's a distinction is because it's an illegal drug. You cannot have it in your possession or you're committing a crime. So the idea behind the regulations was to give that protection for that patient who has a genuine medical need. If they have cannabis on their person, that they're not committing a crime. They're protected from prosecution by having this authorization to possess. It's not an authorized drug. We can't prescribe it. We can't recommend it. We can simply assist somebody who finds it useful and for whom all other avenues have been explored. They can be at least protected from prosecution for possession. Now, of course, that gives rise to an incredible number of potential problems. Because, and as I'll come to in a few minutes, how do you know that the patient in front of you really is using it as a medicine and not recreationally and just telling you that it's medical? I can't measure their pain or their anxiety or their, I can measure spasticity to some extent, but some of these things sleep. So there's potentially all sorts of challenges. And I think this is one of the reasons why a lot of Canadian physicians, where this program is available, shy away from it because they really have a hard time making that judgment in the clinic. And the other problem is that the question is okay, so our patient has an authorization to possess the drug. Where do they get it from? And of course, the act of giving someone marijuana is an offense unless that person's protected as well. So Health Canada did a number of things. It hired a company to grow cannabis for them, much like the company that makes the spray. They were able to grow it in a secure facility, and they provide that to patients. Very small number of patients actually avail themselves of this. Probably around 3,000 now patients are actually accessing the drug from Health Canada's supplier, and it's shipped straight to their door in little gold foil bags. It looks like a bag of coffee beans. But it's sent straight to them, and it's a standardized. We know what's in it. It's been carefully measured, and we know exactly what's in there. But the other options that they have are to either grow it for themselves, so they can actually get seeds and plant them and grow the cannabis for themselves, which intriguingly for some patients is actually kind of a therapeutic act in itself. They like growing their plant and getting their cannabis from the plant. Or they can designate somebody else to grow it for them. And this is where I think we've seen in the last few years a real kind of twist on the process, because the clever cannabis growers realized that if they got enough licenses from people, they could set up little grow ops. And when the RCMP go in to take them down, they simply show their cannabis grow licenses and they're untouchable. So there has been some suggestion that these kinds of designated licenses are being abused, and there's an attempt now to try to correct that. Health Canada is in the process of revising these regulations to try to make it a little bit easier for doctors to participate, to make it harder to abuse at the other end, and make it more available that patients can get cannabis more easily through legal sources. It's a long story, but just so that you know that's happening and will probably play out in the news in the next couple of years as it comes down. But who are these patients? Who is using cannabis and why? And I'll come back to this question of what have we learned from marijuana about pain control. Well, we did a survey in England, published it about 5 years ago, and we asked about 3,000 patients there why they use cannabis. And if you probably can't read this, but I'll read the top few lines, and it's really just intended to show you the list of conditions for which these patients were reporting using cannabis. And I'll read the top 10. Multiple sclerosis, neuropathy, chronic pain, depression, arthritis, gastrointestinal, migraine, allergy, spinal pain, asthenia, weight loss, spinal cord injury, genitourinary pain, chronic fatigue syndrome, epilepsy. So an incredible range of different diseases. And it's only when you try to tie that report with the neurological basis of the drug, when we understand that this is where the receptors are and how they work, it actually makes sense. These are exactly the kinds of conditions that you would expect a neuromodulator like cannabinoids to actually work. They're actually balancing out some of these processes. And this may be why we see such a range of different conditions. We've studied, as a population, marijuana use for 40, 50 years, ever since the early 60s when marijuana kind of exploded onto the recreational scene. People have been studying the effects that marijuana use has in the young, in pregnancy, in various different lung studies. And that paper really is an incredible summary of the literature that's been done on the non-medical use. What we really don't have much information on is people who use it medically. What are the adverse effects? They're probably using it in very different ways. You can see the plasma levels are lower. You sense that they're not using it to get stoned. They're using it to try to improve their pain. So if you use cannabis in that way, are the effects the same? Are they different? We're in the process of trying to tease out the adverse effects of medical use of cannabis. But it's not always clear that the two are necessarily the same. What we do recommend, though, in people who are considering using cannabis for medical purposes, psychosis. It's quite clear now that cannabis has the ability to unmask or worsen a patient, especially young adolescents who have a history or a predisposition to psychosis. It's quite clear now that cannabis is not a good drug for those people, that they can precipitate or can aggravate the psychosis, it can trigger relapses. And so anybody with a history of psychosis or a psychotic disorder, sometimes even a primary relative, a first-degree relative, we tend to avoid using these compounds. Cannabinoids increase your heart rate. They make your heart race. They dilate the blood vessels in your periphery. They dilate the blood vessels in the eye, which is why you get that red eye. And that can raise the heart rate to try and keep the blood volume up. And if somebody with an unstable ischemic heart, we know that that can be a risk factor for triggering angina, in some cases even myocardial infarction, heart attack. Cannabis has been studied quite extensively in pregnancy. The major risk appears to be slightly premature babies, seem to be somewhat lower birth weight in general. Doesn't seem to be any strong evidence that the babies have any risk of being malformed or congenital malformations, but it's still like any other drug not advised during pregnancy. So we avoid it in any kind of pregnancy. As a separate issue, we tend, when I'm screening patients who come, and I get quite a number of people coming saying, okay, can you give me marijuana for my pain? I want to try it. We often ask about histories of legal issues. Have you had, and it's amazing the number of people that I've seen, when I ask them, you know, is any legal issues going on? Oh yeah, I got caught with marijuana 6 months ago, and I'm in cases in court. But if I get my license to possess, then, you know, the whole thing might go away. That does happen. So, you know, we have to ask about that. We ask about use of other street drugs. Is there other behaviors and other substance abuse issues going on which need to be addressed and which might give us a feeling that this isn't entirely about medical use, but there may be other behaviors going on that we have to look out for. Cannabis can be abused. There's no question that, and I often get asked this, and it's happened recently in my own community where, you know, I had a very good friend whose 16-year-old was starting to have troubles with cannabis use and starting to get into problems and having some mental health problems. And it was made clear to me that, you know, well, Mark, where you say marijuana's fine, it's healthy, and it's good for medical purposes, how, you know, this is a major problem. As I said right at the beginning, you know, medical marijuana as a phrase is kind of giving us this feeling that perhaps it is a useful substance. But is that driving kids to use it more? There's a study that I think just came out today that suggests that use of marijuana among teenagers is going up in the US. People are saying that that's because they're seeing cannabis as being safe now, and all these studies are coming out saying it could be useful. It's clearly a risk factor in the young, and the brain is developing in teenage years. The cannabinoid receptors are very important in the way the brain is organizing itself, the way the nerves are starting to arrange and click, and God knows adolescence is a confusing enough time as it is without having cannabis in there changing the whole structure. And we believe that this is really not a good time to be swimming in cannabinoid compounds. The brain needs to be left to be clean and organize itself during that period. So the longer kids can wait to try cannabis, the better. And it's clearly not a message that we want to be giving, that just because we're thinking of medical use for somebody who's 45 with severe multiple sclerosis doesn't mean we're advocating for it in a 16-year-old high school kid. We have to validate that the cannabis is really being used for medical purposes. Is the person improving their function? Are they improving their quality of life? Are they improving their sleep? Are they getting better pain relief? Are they reducing their other medications? So these are very powerful outcomes that we look for in any medication or any therapy for that matter to ensure that the patient is improving. So, wow. That was a good effect. That's for those of you who had the cookies. That was a little test. But can we do this without cannabis? So then my last two slides are to try and explain to you that there may be other ways that we can use this endocannabinoid system without the complicated factor of having to take cannabinoids in. So I'm going to throw a couple of quick bits of data at you in ways that we may be able to do that. We may be using it actually without really knowing that we're doing it. Runners. Any runners in the group? Anybody run? There you go. So cannabinoid addicts. It's been quite well studied now that people who run, and here's the data. So these are the controls. These are people who have been sitting, for you guys an hour ago, you had a level of anandamide, the great CB1 endogenous agonist, in your blood at a level of 2 picomole. This is tiny, tiny, tiny traces per milliliter. And at the end of a 1 hour period, the cannabinoid levels are very similar. Runners with low levels here increase their anandamide levels after running. Cyclists, even more. I always knew cyclists were a little different from runners. Obviously a little more chilled out in some way, but so you see this very important increase in circulating endocannabinoid levels. Just published, this is in June of 2012, is a study that looks at a whole family of endocannabinoids, and this is anandamide here, the AEA, PEA is palmitoylethanolamide and olealethanolamide. These all show increases in plasma levels of cannabinoids after running at 60 minutes, and this is an hour run at 55% capacity. If they then do a burst of exercise, a time trial at 75%, the cannabinoid levels go up even more. Now here you start to see the anandamide levels going up. But intriguingly, at recovery, so this is an hour or two after the exercise is finished, the cannabinoid levels continue to go up. And the theory now is that this rise in endocannabinoids may be why people who've just gone running, we think this may be happening after osteopathic manipulations as well, plasma levels of cannabinoids go up, and you actually start to feel that well-being, that sense that runners in the group are smiling because they know what I'm talking about, that feeling of, I feel relaxed, I feel good, everything's a bit smilier and sharper and the flowers look nicer. It's a cannabinoid effect, and this is clearly shown by the data from the runners and the cyclists. Intriguingly, we've always talked about runner's high as an opioid effect. We've always said that it was endorphins. But if you look at the endorphin data down here in the bottom, you see that sure enough, during that period of intense exercise, yes, the endorphins go up. But during the recovery phase, they start to go back down again. So there's a difference in the way the endorphins are behaving and the way the endocannabinoids are behaving. And this is just published in June of this, in fact, that's a month ahead of now, but it's just published. We're really on the cutting edge here, folks. This is before it was even published. You can see that we're starting to explore how this cannabinoid system is playing a role in normal physiological processes. And so perhaps there's a way. I have a hunch that yoga, and I've done yoga in the past, and there's that sort of feeling of well-being after you've done a really good yoga session. I am convinced that there's a strong endocannabinoid effect, that that's part of this process, and that we're harnessing this without that. So there are natural ways, if you like, of getting cannabinoid effects without having to take marijuana. And the pharmaceutical industry is really, really big on this. They are hunting hard. Because we know about the receptors and the endogenous ligands, they are on the hunt for ways in which they can get molecules into you which are going to play with this system and harness it. And this is just to show you, so there's anandamide again, the endogenous cannabinoid. Once it's finished doing its job, it's picked up by a special membrane transporter and carried across the cell membrane into the cell, and it's broken down there by a special enzyme, fatty acid amide hydroxylase, or FAR, and it's broken back down into its constituents. So it's a beautiful little recycling system. But what the drug companies are trying to do is to block that transporter so that you have more anandamide in the synapse, so that you can have more of that cannabinoid effect. Maybe that would be an effective analgesic, blocking anandamide transport, or blocking the enzyme that breaks down the cannabinoid. And if you block the pathway somewhere downstream, you may build up an anandamide higher upstream, and that could also give rise. And some of these drugs have started to get into clinical trials, and we may start to see these endocannabinoid modulators coming down the pipeline as new medications in the next 5 to 10 years. Again, really, really early days to see this, but just to show you that there are ways that we can perhaps modulate and target this system for pain control without relying on a crude herbal product like marijuana. So pain as a complex disease affects many parts of people's lives. You've been hearing about it for the past few weeks. We know it affects, of course, there's the pain, there's the sleep, there's the mood, and of course all of that leads to impairment in function. People with chronic pain don't function very well, and we need to sort of tackle all of this with the tools that we have at our disposal. And cannabinoids appear to be one more piece of this puzzle that we might be able to use. And just to wrap up then my closing comments, remind you that pain is transmitted chemically by these specialized receptors and chemical messengers and so on. And that the cannabinoid system is a dedicated, specific process by which we think the pain pathways can be modulated, and in fact many other physiological processes as well. We think that the cannabinoids work through this pathway to help pain, sleep, and mood. And that while they're safe, that they're remarkably safe compounds in general, and you can read the adverse effects paper yourself, they're quite safe compared to many other drugs that we use, but they're powerful, and they have to be used carefully. We have to know what we're doing and monitor patients carefully. But in that context, they offer a potentially new approach to pain control. And through studying them, we've understood a lot more about the way our physiology functions. We've studied the brain in different ways using cannabinoid tools. And with that, I will draw to a close. Thank you very much for your attention, and I think now I'd be happy to take any questions. Thank you very much.